start discussing about the adrenocortical diseases. Those are Addison's disease and crisis, followed by Cushing syndrome. These two are important 5 marks questions in RGHS exams. What is Addison's disease? Addison's disease is characterized by chronic adrenocortical insufficiency. Chronic adrenocortical insufficiency due to destruction of adrenal cortex. This is called as Addison's disease. And the adrenocortical insufficiency in Addison's disease, to call it as Addison's disease, there should be adrenal cortex destruction. If there is reduction or reduced level of adrenocortical hormones due to steroid withdrawal or due to pituitary dysfunction or due to hypopituitarism, it doesn't count into Addison's disease. So only primary decrease in adrenocortical hormones is called as Addison's disease. What is the pathophysiology of Addison's disease? Addison's disease can be inherited. Most commonly, it's due to autoimmune attack, and also it can be due to infections. What are the inherited conditions which is causing chronic adrenocortical insufficiency, adrenocortical destruction? This is Aladdin gene mutation and TPIT gene mutation. The autoimmune conditions associated with Addison's disease are polyglandular autoimmune diseases and isolated autoimmune adrenalitis. The infections which are causing Addison's disease is TB of adrenal gland, and also we can have meningococcemia. You all know that Waterhouse Friderichsen syndrome, where there is hemorrhage into the adrenal gland, causing acute adrenal crisis. And also Addison's disease. This is about the pathophysiology. Let's see the clinical manifestations of Addison's disease. The clinical manifestations can be due to decreased activity of mineralocorticoid, which is due to destruction of zona glomerulosa, decreased activity of glucocorticoids, decreased level of glucocorticoids, which is due to dysfunction or destruction of zona fasciculata, decreased level of sex steroids, which are due to decreased destruction of zona reticularis. Let us see the manifestations which are due to mineralocorticoid deficiency. Due to reduced mineralocorticoids level, we will see reduced aldosterone level. We all know that because aldosterone is secreted from zona glomerulosa. This aldosterone goes and act on aldosterone receptors and causes the expression of ENaC channels, epithelial sodium channels. These sodium channels causes reabsorption of sodium and excretion of potassium and hydrogen ions. When there is reduced aldosterone, it causes reduced reabsorption of sodium, increased excretion of sodium, so thereby causing hypovolemic hyponatremia. And also there is reduced excretion of K plus and H plus, causing hyperkalemia and acidosis. These are the clinical manifestations due to mineralocorticoid decrease. What are the clinical manifestations due to reduced level of glucocorticoids due to destruction of zona fasciculata? Those are hypotension, fasting hypoglycemia, hypotension because the glucocorticoid cortisol is responsible for catecholamine acting on sympathetic receptors, that is alpha and beta receptors. The catecholamine sensitivity is increased by cortisol. If it is lost, it leads to reduced activity of catecholamines, thereby causing hypotension, and hypotension can be due to other causes due to reduced glucocorticoids, reduced contraction of heart, and etc. We can see fasting hypoglycemia. Why so? Because glucocorticoid cortisol is responsible for gluconeogenesis. It increases free fatty acid levels and amino acid levels, which is directed towards production of glucose by gluconeogenesis. Why so? Because we all know that cortisol is secreted during stressful conditions. When there is stress, we need lot and lots of energy. So thereby the body secretes the cortisol, will increase the glucose levels in the body by gluconeogenesis. When there is reduced glucocorticoids, reduced cortisol, it causes reduced glucose level, causing fasting hypoglycemia. There can be muscular weakness in case of reduced glucocorticoids level. And also, please note, the patients with Addison's disease most commonly present to you with vague symptoms like weight loss and fatigue. Due to reduced level of sex steroids, the patient can have decreased libido, loss of libido, and loss of axillary and pubic hair. The sex steroids which are secreted by adrenal cortex are three, that is androstenedione, dehydroepiandrosterone, and dehydroepiandrosterone sulfate. When these things are reduced, it causes loss of libido and loss of axillary and pubic hair. These are all the clinical manifestations that are seen in Addison's disease. Now, these are the clinical manifestations due to the adrenocortical insufficiency. We all know that when there is reduced adrenal glands hormones levels, adrenocortical hormones levels, the pituitary, the negative feedback to pituitary is lost. When the negative feedback to pituitary gland is lost, it increases the production of ACTH. Due to increased production of ACTH, we have hyperpigmentation. How ACTH is related to hyperpigmentation? The precursor of ACTH is pro-opiomelanocortin. This pro-opiomelanocortin is broken down into ACTH and MSH, melanocyte stimulating hormone. When there is increased level of ACTH, it causes increased level of melanocyte stimulating hormone, thereby leading to hyperpigmentation seen in case of Addison's disease. The hyperpigmentation will be characteristically seen in oral mucosa and the areas where we see in pressure areas like elbow, axilla, etc. we see hyperpigmentation. And then how to manage these patients? The investigations. We estimate fasting cortisol levels. If the fasting cortisol levels is less than 3 microgram per deciliter, it means that the glucocorticoids level has decreased. This is diagnostic of Addison's disease. If the fasting cortisol levels is more than 20 microgram per deciliter, you should be thinking of other diseases. It can't be Addison's disease. If it is between 30 to 20 microgram per deciliter, now we are in confusion whether it is Addison's disease or not. How to clarify it? We clarify the doubt by ACTH stimulation test or synactin test, where we give ACTH to the patients and see the response. If upon giving ACTH, the glucocorticoids levels increases to more than 18 microgram per deciliter, it rules out Addison's disease. Even after giving ACTH, in case of Addison's disease, the glucocorticoids level will not increase. Why? Because the adrenal cortex is destroyed in Addison's disease, so it can't increase. When it is less than 18 microgram per deciliter on ACTH stimulation test, will confirm Addison's disease. This is about the investigation. Now, how to treat these patients of Addison's disease? We give the patient has deficiency of oral corticosteroids, the glucocorticoids. We give oral hydrocortisone, that is this glucocorticoid. The dose of oral hydrocortisone is 10 to 15 mg per meter square per day in 3 divided doses. That is 10 mg in the morning, followed by 5 mg in the afternoon and 5 mg in the evening. Total dose 20 mg per day. And also, if the patient has associated symptoms of mineralocorticoid deficiency, we will add on fludrocortisone to the patient, that is 50 to 100 microgram. This is all about Addison's disease. Let me summarize Addison's disease for you. Addison's disease is a disease where there is chronic insufficiency, adrenocortical insufficiency due to destruction of adrenal cortex, which may be due to inherited conditions like mutations, Aladdin gene or TPIT mutations, autoimmune conditions like polyglandular autoimmune syndrome and isolated autoimmune adrenalitis, and due to infections like TB and meningococcemia. The clinical features are related to decrease in melanocorticoids level, decrease in glucocorticoids level, and decrease sex steroids levels. Due to decreased melanocorticoid level, we have hyperkalemia, acidosis, and hypovolemic hyponatremia. Due to decreased glucocorticoid levels, we have hypoglycemia, fasting hypoglycemia, hypotension, muscle weakness, weight loss, and fatigue. Due to reduced sex steroids level, we have loss of libido, loss of pubic and axillary hair. And due to reduced adrenocortical level, adrenocorticoid hormones level, we'll have increased ACTH, which causes hyperpigmentation in the oral mucosa, elbow, axilla, etc. How to investigate these patients? We estimate fasting cortisol levels. If it is less than 3 microgram per deciliter, we are happy. We diagnosed Addison's disease. If it is more than 20 microgram per deciliter, it can't be Addison's disease. If it is between these two values, we do ACTH stimulation test. On ACTH stimulation test, if plasma cortisol level is less than 18 microgram per deciliter, we confirm Addison's disease. If it is more than 18 microgram per deciliter, we rule out Addison's disease. Now, how to treat these patients? We treat this patient by giving oral hydrocortisone, which is the drug of choice, 10 to 15 mg per meter square per day in 3 divided doses. And if the patient has associated mineralocorticoid deficiency, we give fludrocortisone. This is all about Addison's disease. Next, let's proceed on to discuss one of the acute emergency in Addison's disease called as Addison's crisis. We have talked about thyrotoxicosis crisis or thyroid storm in the morning session. Now we are talking about Addison's crisis, which is an acute emergency in itself. In Addison's crisis, the patient should have Addison's disease. Along with that, if the patient has acute event like infection, trauma, any surgery or dehydration, where these conditions requires increased level of cortisol for normal functioning of the body in order to cope up with the stress. If the patient has Addison's disease, this stress can't be compensated by increasing the secretion of cortisol. So thereby the patient presents with Addison's crisis. Due to reduced cortisol and melanocorticoid level, the patient will have reduced tone of blood vessels. Due to decreased catecholamine sensitivity, reduced level of mineralocorticoid, the patient will have hyponatremia and severe dehydration. And the gluconeogenesis will be reduced. It will be impaired due to decreased level of cortisol. Let us see the clinical manifestations which are seen in Addison's crisis. The clinical manifestations are shock, out of proportion to the disease that we see. See, we see shock in case of trauma, surgery, or secondary to infection, that is septic shock or dehydration. But according to the severity of disease, if the patient has disproportionate shock, then we should be suspecting Addison's crisis. The patient will have hypotension. This is due to reduced vascular tone, the reason for which I explained. The patient characteristically will have acute abdominal pain, constipation, and hypoglycemia. Hypoglycemia, why? We know, due to reduced glucocorticoids level. The patients with Addison's crisis present with shock, acute abdominal pain, constipation, and hypoglycemia. What are the investigations that we do in these patients of Addison's crisis? If we do the investigation due to reduced glucocorticoids level, we have reduced sodium levels, increased potassium levels. We will have hypoglycemia due to reduced glucocorticoids, and we'll have eosinophilia, because glucocorticoids are responsible for reducing eosinophil levels. When they are reduced, it causes eosinophilia. How to treat these patients with Addison's crisis? We should give IV fluids, large amount of IV fluids, because the patient have severe dehydration in case of Addison's crisis. The sodium and water is being lost in the urine due to reduced aldosterone. The patient can have severe dehydration in case of Addison's crisis, so we should give IV fluids. We'll connect a large bore cannula and give 0.2 0.9 ns or DNS over 1 hour, give 1 liter of fluid over 1 hour, followed by 2 to 3 liters of fluid over next 12 hours. 0.9% of ns over 1 hour, we give 1 liter, followed by 2 to 3 liters in next 12 hours. Then we give IV hydrocortisone to the patient. That is, we'll give 100 mg stat, followed by 50 mg IV infusion every 6th hourly. And then the IV infusion will gradually taper over 1 to 3 days. Following that, once the patients recover from Addison's crisis, we'll give 20 mg hydrocortisone with or without fludrocortisone as in case of Addison's disease. This is all about Addison's crisis. To summarize, Addisonian crisis is seen when the patient with Addison's disease has acute event like infection, trauma, surgery, and dehydration. This causes shock, acute abdominal pain, constipation, and hypoglycemia. The investigation findings are hyponatremia, hyperkalemia, hypoglycemia, and eosinophilia. The treatment of the condition, we have IV fluids, 0.9% ns over 1 hour, that is 1 liter over 1 hour, followed by 2 to 3 liters over next 12 hours. And then IV hydrocortisone will give 100 mg stat, followed by 50 mg IV every 6th hourly. And then we'll taper the dose over 1 to 3 days, followed by normal oral dose that we give in case of Addison's disease, that is 20 mg hydrocortisone plus or minus fludrocortisone. This is all about Addisonian crisis. I want to discuss another interesting topic, that is Cushing syndrome. Cushing syndrome is the clinical consequence of increased circulating glucocorticoids. In Addison's, we see decreased secreting adrenocorticoid hormones. In Cushing syndrome, we see increased circulating glucocorticoids, which may be due to exogenous intake of glucose or due to endogenous diseases. The most common cause for Cushing syndrome is the exogenous intake of hydrocortisone, prednisolone, or other steroids. If the Cushing syndrome, the glucocorticoid insufficiency, the reduced glucocorticoids level is caused by pituitary microadenoma or macroadenoma, secreting increased ACTH, causing increased level of cortisol, it is called as Cushing's disease. The Cushing syndrome, it includes both exogenous and endogenous causes, whereas the Cushing's disease is the disease where the corticosteroids level are increased due to pituitary micro or macro adenoma. What is the etiopathophysiciology of Cushing syndrome? The Cushing syndrome can be ACTH dependent and ACTH independent. Let's review the physiology a little bit. From the hypothalamus, there is release of gonadotropin releasing hormone, which causes pituitary gland to secrete ACTH, which stimulates the adrenal cortex to secrete glucocorticoids mainly. If the diseases which causes Cushing syndrome, that is increased glucocorticoids levels, can be due to diseases of adrenal glands, or that is tumors of adrenal glands, or can be due to tumors of pituitary which causes increased ACTH levels. So we have two types of causes, two broad classification of etiopathophysiciology of Cushing syndrome. Those are ACTH dependent Cushing syndrome and ACTH independent Cushing syndrome. 90% of cases of Cushing syndrome are due to ACTH dependency, meaning there is increased secretion of ACTH, causing increased release of cortisol. The ACTH dependent most commonly is caused due to pituitary adenoma, which is called as Cushing's disease. It can also be, the ACTH can also be secreted by ectopic tissue, ectopic tumor mass, that is called as paraneoplastic syndrome. We see small cell carcinoma of lung, pheochromocytoma, and medullary carcinoma of thyroid secreting ACTH, causing Cushing syndrome. What are the ACTH independent causes? The ACTH independent causes will be adrenal tumors. We have adrenal adenoma, which is a benign disease, and adrenal carcinoma, which is a malignant disease, as the ACTH independent causes of Cushing syndrome. We also have another important cause of Cushing syndrome, that is McCune-Albright syndrome, which is characterized by triad of precocious puberty. Precocious puberty due to increased sex steroids, fibrous dysplasia, and cafe au lait spots. Here you can see cafe au lait spots, the macules that you see. This is about the pathophysiology, ACTH dependent and ACTH independent causes of Cushing syndrome. What are the clinical manifestations of Cushing syndrome? The increased cortisol level, hypercoagulable state. In case of stress, fight or flight response, the body can sustain injury and bleeding. Due to that, increased cortisol level is been associated with increased thrombosis, which causes hypercoagulable state. So the patient will be having increased risk of coronary artery disease. This is one of the point to note. Now, what are the clinical manifestations that we see in Cushing syndrome? We have the manifestations due to protein catabolism. Why protein catabolism? The body breaks down the proteins from the muscles and releases amino acids, which enters into the gluconeogenesis pathway, and production of glucose, the energy which is responsible for fight and which gives energy, ATP, for fight and flight response. When this response is increased, it causes pathological conditions, pathological manifestations. Those are proximal myopathy, that is proximal muscle weakness due to their breakdown due to excess glucocorticoids. It is bilateral, asymmetric, and lower limbs are more involved compared to upper limbs. Due to protein catabolism, we have thinning of skin. Due to that, we have bruising and ecchymosis of skin. And also, due to protein catabolism in the bones, we have premature osteoporosis leading to pathological fracture in these patients. We all know that glucocorticoid causes increased glucose level, hyperglycemia, which causes diabetes mellitus in these patients with Cushing syndrome. Now, head-to-toe manifestations seen in these patients, what are those? In the CNS manifestation, the patient can have steroid-induced psychosis, the acute frank psychosis. The patient can present to you with depression and psychotic symptoms. There can be CNS irritability. We have characteristic moon face and red face. Please note, the patient has increased susceptibility to infection, even though the WBC level are increased in case of Cushing syndrome. The WBC level increased because the glucocorticoid, the cortisol normally increases WBC levels. So here the glucocorticoid increase causes increased WBC levels. Even though the WBC level is increased, there is increased susceptibility to infection. Why so? Because this increased glucocorticoid levels impair the functions of adhesins, which are responsible for adhesion and migration to the site of infection. Due to that reason, there is increased susceptibility for infection. So the patient with Cushing syndrome can present to you with systemic fungal infection due to increased susceptibility to infection. Systemic fungal infection. This is the reason why the glucocorticoids are immunosuppressants. So we can have systemic fungal infections and other bacterial systemic infections. Hyperglycemia we see in these patients, and also please note, we see gynecomastia in these patients. Why so? Because The increased cortisol levels causes redistribution of fat and central obesity. Due to increased fat levels, it causes increased peripheral conversion of androgen to estrogen. This is responsible for gynecomastia in males. In females, it causes amenorrhea and hirsutism. There can be purple striae due to collagen impairment. And also, I told bruising and ecchymosis, it is also due to impaired collagen strength seen in these patients. We have thin skin already discussed, bruises and petechiae already discussed, osteoporosis already discussed. These are all the clinical manifestations that we see in these patients with Cushing syndrome. Now, how to manage these patients? The investigations we have, first, we should confirm whether the patient has Cushing syndrome or not. Followed by that, we can proceed on to find the cause of Cushing syndrome. How to detect whether the patient has Cushing syndrome or not? We do midnight serum cortisol level estimation. Normally, physiologically, from 8 a.m. to 12 p.m., the plasma cortisol level is low at midnight. If the normally, that is, plasma cortisol level is less than 1.8 microgram per deciliter, this is normal level. If it is more than 1.8 microgram per deciliter, it suggests Cushing syndrome. Also, we can also do 48-hour low dose dexamethasone suppression test. What is this low dose dexamethasone suppression test? Normally in the body, if we give exogenous steroids, the endogenous steroid secretion will be reduced. This is the normal physiological response. But in the patient with Cushing syndrome, it doesn't occur like that. Let's see what it is. If we give dexamethasone 0.5 mg 6-hourly to these patients for 48 hours, after that, if we estimate plasma steroids level, cortisol level, then normally it should be less than 1.8 microgram per deciliter due to reduced endogenous production of steroids normally. But in the patients with Cushing syndrome, the levels will be more than 1.8 microgram per deciliter. We discussed in both of these midnight serum cortisol level estimation and 48-hour low dose dexamethasone test. If the cortisol level is more than 1.8 microgram per deciliter, it suggests Cushing syndrome. Now, let's see how to find out the cause of Cushing syndrome. We have established that the patient has Cushing syndrome. Now we are going to see why the patient has Cushing syndrome. We all know that the Cushing syndrome can be ACTH dependent and ACTH independent. So we estimate a plasma ACTH level. If it is more than 10 picogram per ml, it is ACTH dependent tumor. If it is less than 10 picogram per ml, it is ACTH independent tumor. If the tumor is ACTH dependent, we see what are the other things that we do. Before that, let's see what are the, if the ACTH level is less than 10 picogram per ml, meaning that the tumor is ACTH independent, meaning that the patient have adrenal adenoma or adrenal carcinoma. So in patients with ACTH level less than 10 picogram per ml, we'll carry out CT scan, where we can see whether there is unilateral adenoma or bilateral adenoma or hyperplasia of adrenal gland. If the patient has unilateral adenoma, we perform unilateral adrenalectomy, and thereby we will be treating the Cushing syndrome forever. If the patient has bilateral disease, bilateral adrenal hyperplasia or a bilateral adrenal adenoma, we perform bilateral adrenalectomy, thereby curing the disease. So, what to do if the ACTH level is more than 10 picogram per ml? If it is more than 10 picogram per ml, we see whether it is between 10 to 50 picogram per ml or more than 100 picogram per ml or between 50 to 100 picogram per ml. If the ACTH is between 10 to 50 picogram per ml, it is most commonly due to pituitary adenoma. If it is more than 100 picogram per ml, it is most commonly due to paraneoplastic syndrome. The three paraneoplastic syndrome causing ACTH, Cushing syndrome we saw can be due to that. In those patients with more than 100 picogram per ml, we perform PET CT scan, find out the source of ACTH and treat accordingly. Treat medullary carcinoma of thyroid, pheochromocytoma, and also small cell carcinoma of lung. If the values are less than between 10 to 50 picogram per ml, we perform MRI with gadolinium, thereby confirming pituitary adenoma, and then we can perform transsphenoidal hypophyseectomy, thereby removing the pituitary adenoma and thereby curing the disease. What if the patient has the level between 50 to 100 picogram per ml? It may be pituitary or paraneoplastic syndrome. We'll first do MRI and gadolinium scan in these patients. If they have pituitary adenoma, we perform transsphenoidal hypophyseectomy. If they have paraneoplastic syndrome, we perform PET CT, find out the cause and treat adequately. If the patient is unfit for transsphenoidal hypophyseectomy, we can perform radiotherapy in this patient. Now, what if the surgery is delayed? Till that time, we can give ketoconazole 200 mg TDS for the patient, which reduces the production of cortisol. The dose can be increased up to 400 mg per twice a day. If there is recurrent tumor after all this surgery, we can treat the patient with ketoconazole or mitairapone. This is all about Cushing syndrome. Let me summarize Cushing syndrome fastly for you. Cushing syndrome is a clinical syndrome characterized by increased glucocorticoid level, which is most commonly due to excess intake of glucocorticoids, that is hydrocortisone, prednisolone, etc. We have Cushing's disease, which is the increased corticosteroids level due to pituitary micro or macroadenoma. The pathophysiology, ACTH dependent one and ACTH independent. ACTH dependent are pituitary adenoma and paraneoplastic tumor. ACTH independent are adrenal adenoma, adrenal carcinoma. We have other McCune-Albright syndrome causing Cushing syndrome. The clinical manifestation we saw the related to protein catabolism. We have proximal myopathic thinning of skin, bruising, ecchymosis, osteoporosis, and also the patient may have diabetes mellitus. We also see steroid-induced psychosis, moon facies, edema, fluid retention, hyperglycemia, gynecomastia, redistribution of fat, central obesity, thin skin bruising pedicay, and osteoporosis. The investigations how to manage this patient, we saw first we'll confirm whether the patient has Cushing syndrome or not by 48-hour low dose dexamethasone test and midnight serum cortisol test. If the values are more than 1.8 microgram per dl in both these, it suggests Cushing syndrome. Then we'll go on to find the cause of Cushing syndrome by ACTH estimation, plasma ACTH estimation. If it is less than 10 picogram per ml, it is most commonly ACTH independent, that is adrenal adenoma or adrenal carcinoma. We'll do CT scan and we'll do unilateral or bilateral adrenalectomy based on the cause. If the value is more than 10 picogram per ml, it is the tumor is ACTH dependent. The Cushing syndrome is ACTH dependent. We see whether the values are between 10 to 50 picogram per ml, whether it is more than 100 picogram per ml or between 50 to 100 picogram per ml. If it is between 10 to 50 picogram per ml, it suggests pituitary adenoma, where we do MRI with gadolinium and we perform sphenoidal hypophyseectomy. More 100 picogram per ml, it suggests paraneoplastic cause, and we will do PET scan in these case patients. If it is between 100 and 50 and 100 picogram per ml, first we will do MRI with gadolinium. If the patient has pituitary adenoma, we will carry out transsphenoidal hypophyseectomy. If not, we will do PET scan and see whether the patient has paraneoplastic syndrome. So if the patient surgery is delayed, we can temporarily manage the patient by giving ketoconazole 200 mg TID, which can be increased up to 400 mg TID. If the patient has recurrent, you will give the ketoconazole and mitairapone to the patient and manage the patient. This is all about Cushing syndrome.